All right. Hello, everyone. I'm Stacy Felvey. I plan the adult programs at the Lake City Public Library. Thank you for tuning in to our Zoom event tonight. We're very excited to have Dr. Robyn Birkeland from the U of M with us. Dr. Birkeland is a study counselor for families and long-term care projects at the University of Minnesota and has more than 20 years experience in counseling and support protocol to families. She collaborates with family members, typically adult children or spouses, guiding them through the transition process of moving a family member into long-term care. Before we get started with the program, just a quick reminder of some of our future programming at the library. There'll be a craft outside the library as part of Junk Crush at Johnny Appleseed Days on Saturday, October 9th. We have a live event with Minnesota author Alan Eskins coming up, a cooking demo with Margot Yoder, which is also via Zoom, a book discussion on The Art of Dying Well by Katie Butler. Specific information about each of these events is available on our library website. And regarding our program tonight, we ask that you please keep your mute button on. And there will be several opportunities throughout the program when Dr. Birkeland will take your questions. You can also use that chat feature, and you can send your questions directly to me if you don't want to ask them yourself. And then I can ask the questions for you. Otherwise, you can also unmute yourself when we have those times for the questions. She will also provide her email at the end of the program if you'd like to send her your questions privately. So at this time, please join me in welcoming Dr. Birkeland.
Thank you. So, just real quickly, I work with the Families and Long-Term Care Projects team at the University of Minnesota in the School of Public Health. And we do a lot of intervention studies, working with caregivers. One of our studies looks at the transition into long-term care and how to support caregivers in that transition for individuals with memory loss. But we also have a study that is supporting both family and retiring drivers for someone who has memory loss and is either planning at some point down the road to retire from driving, or is currently going through it, or even has retired and is just kind of adjusting to that driving retirement. So that's another study that we're doing. And we have other ones as well, but it's really about supporting the caregiver. So that is like our main focus. And I'm very happy to answer questions, as Stacy said, either during this, or if you don't want to ask in front of other people, or you think of something later, feel free to email. I'll have my email up at the end, and they'll be in the slide deck, which will be on the library website. So anytime, just let me know. So we're going to go through, and the slides I have, not this one, but most of them I packed a lot of information on. And it's not that I will necessarily talk point by point about what's on the slides, but I just want you to have that information for later if you ever want to refer back to it. There's like an addendum to this where it just talks about caregiver support. So different resources and things like that. So that's just not that I'm going to get through it all tonight. That's just there for future reference for you if you ever have any interest in looking at that. But tonight we will focus really on the kind of the basics of dementia and Alzheimer's. First question being, are Alzheimer's and dementia the same thing? Because we often hear them like kind of referred to as the same thing, but they're not. Dementia is really, it's not even a specific illness. It's a collection of symptoms. And there are over 100 types of dementia, including juvenile dementia. So it's not necessarily just an adult disease, but it is kind of like this broad umbrella. And I will show you more about that in the next couple of slides here. But when you are talking dementia, it's the umbrella. Alzheimer's is one type of dementia, but there are a myriad of other dementias, and they may not even have memory as a symptom. So to be considered dementia, you have to have at least two of the following. You have to have either memory, communication and language, your ability to focus and really kind of pay attention. Reasoning and judgment can be impaired, or even just vision. So you could have a dementia that really affects vision and judgment, and that is not, like memory is completely intact. but we often think of dementia as a memory disease and Alzheimer's as a memory disease, and therefore they must be the same thing, but they are different. So it's, you know, it's interesting how we got to that point where we considered Alzheimer's and dementia the same. I'm popping up now, oops, went too far, 4 of the like most common types of dementia, because even though, like I said, there's over 100 of them, these are the 4 most common. Alzheimer's being the most common. About 60% of dementia is Alzheimer's disease. But vascular dementia, and we'll talk a little bit about all these, but vascular dementia is another type of dementia that is fairly common, Lewy body dementia and frontal temporal. And so if someone is diagnosed with dementia, the odds are they're going to be diagnosed with one of these 4, but there are other types as well. And, you know, another piece of this is that mixed dementia is a very common experience as well, where you might have Alzheimer's and vascular dementia. And so we'll talk about this a little later, but the diagnosis process can be difficult because it's kind of hard to figure out exactly what someone has, and we'll go through that in more detail of why that is. See, I probably have already said all this. Yes. And so at the bottom here, I break it down into percentages of like I said, like 60% of dementia is diagnosed Alzheimer's, but then 20% is vascular dementia, 15% Lewy body, 5% frontal temporal. And so there's like just a small percentage that could be something different. But there's a lot of something different that it could be. And it's very difficult for someone to get a diagnosis of something different. And it's hard for support and for, you know, for families, for caregivers, for everyone to try to figure out how best to support someone with a different diagnosis, because we know so little about those different dementias. But some people would argue that it doesn't matter what kind of diagnosis of dementia it is, because the treatment plan is all the same. And essentially, you know, you're taking care of, you're doing things like helping change the environment to make things more simple and scheduled and just kind of less overwhelming. You're going to do that for everyone who has dementia. It doesn't matter what type of dementia it is. You're going to, you know, everyone with dementia will end up needing to retire from driving at some point. So we need to plan for that. We need to plan for certain things. So some people would say it doesn't really matter what the dementia type. Others are like, yeah, it absolutely does, because we need to know kind of the trajectory of this and where it's going, and be able to kind of plan ahead to support the various different things that you'll see. So we will talk through the various different things you might see with the different dementias. Just real quickly on this, mild cognitive impairment is kind of historically been considered like a predecessor to Alzheimer's. Like if you have mild cognitive impairment, you're going to develop Alzheimer's at some point, but you're just kind of in like an early stage of it. But what they have found is that's not actually the case. That there are a lot of people who have mild cognitive impairment who don't progress, that it just stays mild cognitive impairment. And so it's not this kind of absolute that you go from one to the next. So you can be very functional with mild cognitive impairment. And so it's not, you know, it's not as impactful as a diagnosis of dementia. So it's kind of nice to hear that it doesn't automatically go from one to the other, and that you can have that diagnosis for the rest of your life and not progress. Vascular dementia, though, this again, about 20% of dementia is vascular dementia, and it really is a result of not having adequate blood flow and oxygen to different parts of the brain. Often you might see it after having mini strokes or some other kind of impact injury to the brain where that brain tissue is damaged because it's not getting that blood flow. The thing that makes vascular dementia more tricky to diagnose, and there's also there's things that make it more tricky, things that make it less tricky. If you have an obvious, okay, I know exactly what the brain injury was, there is a stroke, now you can say, okay, that's vascular dementia. It makes it, you have that event, which you don't really have in other dementias. However, because it may not be this big event, it might be these minor mini strokes that you don't really know about. Wherever it is, like those strokes have occurred, will impact your brain differently, because if it happens in the language area of your brain, then you're going to have obviously some difficulty with language. If it happens in the frontal temporal lobe or the frontal lobe, it might impact your judgment and your reasoning. So wherever these, injuries occur, it's going to look different. So with Alzheimer's, you can kind of say, okay, this is the progression you would normally see. With vascular dementia, you're not exactly sure how exactly it's going. And it's hard to say, okay, well, they're having memory issues. It's vascular dementia. You might just assume it's Alzheimer's, and that therefore the diagnosis is a lot harder. But it's interesting that it's very different from person to person, depending on where those injuries occur. And I can talk more specifically about that when we talk about Alzheimer's as well. Another type of dementia is Lewy body dementia. And this is a dementia that occurs when these Lewy body proteins are in your brain, and they just start really kind of impacting how your brain is able to communicate. And we'll talk about this with Alzheimer's too, but how your brain cells are able to communicate with other brain cells. It typically affects the motor region of the brain, and it is the exact same antibody, the exact same protein body that affects Parkinson's. So they're very much related. So to the point where if you have Parkinson's first and then develop dementia, they'll call it Parkinson's dementia. If it's the Lewy body first, it'll be Lewy body dementia, Parkinson's. So they're very, very connected. Not to say that you'll have one for sure if you have the other, but that they definitely are often seen together. And some of the kind of like the hallmarks of Lewy body dementia are hallucinations that are very, very intense and very real, that can happen quite often. You have what we call REM, sleep behavior disorder. Essentially, when you are sleeping, you're dreaming, your body goes into a sleep paralysis so that you don't act out your dreams. With this REM sleep behavior disorder, that doesn't happen. So your body doesn't go through the paralysis, so it can act out whatever your dreams are, which can end up being very unsafe, because if you're walking somewhere, you might be walking somewhere. If you're punching someone in your dream, you might be punching the person that's sleeping next to you. So it can be a very difficult, especially for caregivers, part of Lewy body dementia. What you don't see as often with it is a memory issue. This is really more of a judgment and reasoning and that motor function piece. And so in working with families who have a family member with this dementia who have moved their loved one into long-term care, it can be every transition can be difficult. With this one, because you don't have that memory, they remember very well, like it can make it even more difficult to explain why they need the long-term care. But as I've noted, having a lot of hallucinations and having this sleep behavior disorder that can be very difficult for caregivers. It's very hard for them to take care of someone 24/7 under that kind of emotional duress and exhaustion. Frontotemporal dementia is a dementia that really impacts the frontal lobe and the temporal lobe, particularly the temporal lobe side that is responsible for language, so the left side. The frontal lobe is like our reasoning and judgment and weighing consequences and just really kind of like our filter and our higher level thinking. And so quite often when someone has frontal temporal dementia, you will see really bizarre behavior or very inappropriate, socially inappropriate behavior from people who have never done anything even remotely close to what they're doing. So just that can be very, very difficult for caregivers when out and about. It is the most common type of dementia in people under 60. So it happens earlier than a lot of other dementias that which might happen in older ages. There's a lot of different types of frontotemporal dementia. The behavioral one, which was the one I was talking about, is probably the most common, where you are having that just crass behavior and just poor decision making, maybe writing checks to every fundraiser group that is calling, or every, like just like, oh, I need to do this, I need to do that, and spending a lot of money that doesn't need to be spent. That is something that one of the families that I worked with, that was kind of the impetus for a move to long-term care, because they couldn't keep up with trying to take care of all these expenses that were coming in that shouldn't have. But also then language is another area that can be impacted, different type of variant, but you might have, someone who has this aphasia where it's very hard speaking. It's hard for them to speak. And so they might understand that's what a cup is, but they might not be able to say the words. And so that can be difficult as well. And then we talked about mixed dementia. Just before we head into Alzheimer's more deeply, this is a kind of it shows risk factors. And some of these risk factors are things that we can't do anything about. Just that's how it is. But some of them are more environmental, that we can have an impact on. And so this is kind of showing what that is. So 65% likely we can't do anything about, but there's 35% of things that we have some impact on. Now, education, that we don't have any impact on at this point. Like it's, early life, have more education. That ship has sailed for a lot of us, but having less education can be a risk factor for dementia. When we get to midlife, there's some, and actually these are for late life as well, but there's some more health issues like hypertension, obesity, diabetes, smoking, physical activity. Like if we can just do some good, healthy living, and try to, if you have hypertension or diabetes, to medicate and take do what you need to get that under control, then it really helps. The hearing loss piece is interesting, because the other ones kind of make sense, right? Like, oh, we know, like we've heard a lot about heart health and, like what to do to be, physically active and good diet and all that. But the hearing loss was something that they had found a relationship with hearing loss and dementia. But then they were able to go one step further and say, you know what, it actually turns out that this is a risk factor. So if you have hearing loss in midlife, so not when you're older, but in your midlife, if it's not corrected, then it can be a risk factor. So if you have hearing aids or some other kind of hearing support, that's not a risk factor. But having that hearing loss and not treating it can be a risk factor for dementia. So the take-home message from that is, eat healthy, make sure that you're exercising and are socially active, and try to take care of those heart health issues and obesity and diabetes, but also, if you have hearing loss in midlife, to look into a hearing aid or some other kind of hearing apparatus that can help, because it can, that's a 9%, it's higher than hypertension, and it's a higher risk factor than obesity. It's even higher in late life than any of those, like smoking, depression, inactivity. So it's a pretty big one. Yeah. So and there are some theories about why it's hearing. It may be that it is it causes you to be more isolated because you're not able to hear as well. You're not engaging in conversation as much. You're not taking part in participating. So it could be something like that, or it could be something related more like a physical issue. but they're not sure exactly at this point why they would have that relationship. So actually, before I jump into Alzheimer's, I guess this would be a good enough time. Are there any questions about any of the other dementias that we talked about? All right, I will carry on then. So Alzheimer's is a dementia that affects memory, and it affects thinking and behavior. It is progressive, as all the dementias that we talked about are. So it does get worse over time, and we don't have a cure for it. We have some, like I mentioned earlier, environmental things we can do to help make things easier. We have some medications that we'll talk about, but we don't have a cure for it. So we're going to get a little sciencey here, not too much, but a little bit. And I will keep it in plain terms, but what you're looking at is on the left-hand side, a picture of a healthy brain, on the right-hand side, a picture of a brain with Alzheimer's. The first thing you might notice about the Alzheimer's brain is it's smaller, and that is what happens with Alzheimer's. The brain shrinks, and there are a few reasons for that. One thing you're seeing are plaques, and the plaque is a naturally occurring protein that is in your brain, no problem. But for some reason with Alzheimer's, and we haven't figured out why yet, that plaque or that protein, it either is there's just a massive amount of it made, or for some reason the brain isn't absorbing what is made. Whatever is happening with it, there just becomes this, it accumulates, and the protein then sticks together and forms this plaque. The plaque gets in the way of brain cells communicating. So this is a brain cell and this is a brain cell, and they're trying to talk to each other. There's plaque in between and they can't communicate. And that communication is what tells your brain to raise your hand or to speak or to access a memory. So it really impacts the communication process. So that's one piece that's going on. And then the other piece that we know about are these tangles. Again, a naturally occurring protein, this tau that's found in your brain. And I like to kind of think about it as if you're thinking about parallel highways. If you were to like open up the brain cell, you can kind of see it in this picture, but there are like these parallel fibers. And that's how like we get our nutrients to the brain cells. So if you think about it as like a delivery van going down a parallel highway, and it's stopping and it's delivering its nutrients along the way. But with the tau, it causes these tangles or knots in the road so that the delivery van can't get past that knot, and it can't deliver the nutrients that the brain cell needs past the tangle. So those brain cells essentially starve and die. And that's why the brain, you can see it shrinks, because it's having that problem. So you have like these two functions for sure. We know for sure that the tangles are causing our brain cells to not get the nutrients they need and die. And we have these plaques that are blocking other brain cells from communicating with each other. So we can't get what we need. We have a lot of brain cells in our brain and a lot of different pathways that we have created over our life, especially in our adolescence. The brain is really maturing and really becoming who it will be as an adult. And so whatever things, habits that you are doing, the behaviors you're doing, what you're learning, the more you do something, the stronger the connections are and the more connections you have between brain cells. And so, we really kind of have these strong pathways. And so the plaque starts to block off some of them, but you can still access because you have these other pathways you can use. But over time, the plaque will block all of the pathways, and then it'll be, virtually impossible to access the next brain cell to have that communication. But it's not like it happens all at once, because there are other ways to get to that information. We also know that the ventricles, which are these fluid-filled spaces in your brain that are always, they're always there like that, but they grow bigger. So there's more fluid and less brain material, brain matter. So that's another process that happens. But there has to be other things going on because the drugs that we have made so far have been targeting these and it's not helping. So we'll get to that a little bit, but those are the three processes that we know are happening. And here's just another picture where you can see on the right, the ventricles, the dark spaces in the middle are a lot bigger than the ones on the left side. And then this just shows kind of how basically how Alzheimer's attacks the brain. So if you're looking on the left at the mild, there's just a little bit of blue, and that's starting off in the area of the brain that's responsible for memory, which is why we think of Alzheimer's, it's memory. That's the first sign we see is usually, mom used to always make dinner on Sunday nights, and the last couple Sundays we've gone over, she hasn't made it, or she's forgotten the recipe that she always knows and doesn't need, to look at the nose for. She's done it all of her life. So that's where it starts, in the memory area. And also disorientation is around there as well. So, that's kind of getting lost in a familiar place. Not like, I don't know why I'm driving here. I don't recognize where I am. That is some of the early areas of the brain that gets affected. And you can see the blue starts to spread. That's basically the Alzheimer's disease spreading and attacking other areas of the brain with more plaques and tangles forming. And so you move on from that kind of memory and disorientation. You might move into more of emotions being impacted, and that's something that can be much, like, we're not talking about like, oh, he's a little sad today. It's like somebody who is never crying might be crying all the time, or a lot of anger from somebody who you don't, like, that's just not how they are, or just really strong reactions to things that wouldn't have necessarily bothered them before. So you might see some of that along the way. And then in the bottom, the severe, you can see where it's pretty much spread almost all over the brain. So there's balance and movement that's impacted, in coordination. So you might see a lot of falls. Sometimes vision can get involved, where you might have trouble seeing yourself in space. So like if you're walking in a hallway, you might think you're totally clear of a wall, but actually bump into it. And oftentimes at memory care centers that are specifically designed for memory care, they'll have like rounded corners or bumpers on their wall so that you have like a softer landing than those sharper edges that we have. There might be some vision issues in just trying to recognize what things are. There could be language issues in trying to be able to name things, or to remember, like, part of it's memory too, but like just to remember your full sentence, like from start to finish what you were saying. So there's impacts like that. There's judgment, and that the front area of the brain, the frontal lobe. And that's where also, like, as I said, you'll see the in frontal temporal, but just like judgments off, that filter is gone. So that in combination with language being impacted, but the area of the brain that is responsible, or kind of holds, not responsible for, but holds bad language, bad words or derogatory words, we know that that's not good. So we store it in a different place than our regular language, and that place is not affected. So those bad words, or things that people would never say, are at the tip of their tongue because it's easily accessible, and that filter is gone. So you may hear a lot of things that you're like, oh my goodness, but there's not that, wait a second, I shouldn't say that's gone. And it's just the closest thing. I want to be able to express myself. I can't express myself, but here's a word I can say. And so things come out that way as well. So there's that as well. So there's a lot of a lot of the behavior and personality changes that you may see are just biology explained by the science of like how this is occurring in the brain, the areas it's impacting. So, if somebody's getting more aggressive than they used to be, part of it is put it into perspective of if you're reaching out to touch somebody and their vision's a little off. And actually there's this thing, and you can look it up on YouTube. It's like Tifa Snow talks about it in her videos, and she's fabulous. But she talks about binocular vision and how like that's how someone with Alzheimer's sees. Like you don't really have the peripheral, you can't see up and down, which is why there's a stain on your shirt, you're not going to see it, and you would wear that shirt again because you don't remember that you wore it before, you don't see the stain, so no big deal. But if you have somebody coming at you from an angle that you don't see them come from, and they're putting their hands on you, just to gently ask you to go somewhere, just a gentle touch, but you don't recognize where that person is coming from or what they want you to do. Your initial thought may be, I need to get this person off of me. I don't know who's touching, get off. And without that filter and without that ability to say, wait a second, let me rethink this. They're probably just trying to get my attention. Like you may see somebody get more aggressive and just swipe away. Hey, stop. Add into that not being able to really access language as well and express themselves is very difficult to like get their message across, and so it's like, it's much easier to express yourself physically sometimes if you're not able to express yourself with the language. So all that to say, with someone with Alzheimer's, keep in mind that none of this is meant, like it's not done on purpose, and it's not something that they're doing to intentionally annoy or bother or be mean or rude. It's a brain under attack, and how what they're doing is just represents that, and it's a symptom. It's not just like if they had kidney disease, they may have some issue. Like this is unfortunately the issues of the brain. We kind of talked through some of these, but I just want to throw them up. Early stage, mild Alzheimer's, that memory and concentration, problems coming up with the right word or name you might see, or remembering names when introduced to people. You might forget something that you just read, misplacing something, that's a huge one, just like losing stuff around the house, and trouble with planning or organizing are some things you might see. I do want to mention too, with the losing, there's also a piece of the emotion puzzle that is paranoia. So it's like a step above, but it's something that's very common in Alzheimer's, and something that you might see often because it is reinforced. Because if your husband puts his phone down on the table and then leaves and he comes back and the phone's not there, he knows he didn't take it. Somebody took it, and like who would take my stuff? You must have taken it. But what actually happened was he took it and he put it somewhere, and just doesn't remember that. But because it's missing and he knows he didn't do it, it becomes, somebody has stolen this, or somebody is trying to make me look like I don't know what I'm doing, or that paranoia kicks in, and it gets reinforced a lot. And even if you find it somewhere, they may not remember that they put it there, or like oftentimes things will end up in places that don't make sense, and that they recognize, like at the time it made sense to, like to put it in a shoe, but not anymore. And so like I would never put it in a shoe. Like who would put it in a shoe? And so it just really kind of can build, and it's very hard to kind of like get to bring in rational way. I wouldn't put in a shoe either. Arguing is never going to work. That's probably on a slide somewhere, but just to put it out here, like with someone with dementia, their brain is under attack, and the rational, oh yeah, that makes sense, and reasoning, it's not there. So your arguing back is only going to make them dig their heels in and be more, this is absolutely what I know. So our first rule is like never argue, and sometimes it's like, it's a lot easier to just walk away from something like, okay, she thinks I put the phone in the drawer. All right, that's fine, whatever. Like I can deal with that. Sometimes it's a lot harder if it's like mom saying that dad's cheating on her, but dad passed away 10 years ago and that's why he's not visiting. It can be harder on some things, but our golden rule is really just try not to argue, because it's only going to end up making everyone more upset. So if you can steer clear. And then, kind of in the same vein, we talk about like, well, should I tell mom that dad died? Because she's asking about him. That is one of those things where we really say, weigh it out. Like, does she really need to know? Does she need to know because she absolutely has to, or is she just asking because she misses him? And possibly you could tell her a story about him, or reminisce, or distract, or something else, to get her to think of something else, or to make, to fill, like, look for why she's saying it, try to fill that need. Like if she is missing him, maybe you could tell her a story. Say, I was thinking about dad and the time we all went to the beach and blah, blah, blah. Because it's going to be reopening a wound. And so you have to kind of weigh it out. Like, do they really need to know? And if they do need to know, how much is this going to hurt them? And is it worth the emotional distress it'll bring? And most oftentimes it's not. And if you can get away with it, but if you feel like, what, she does need to know. Like, she's been asking me every time I see her and she's in distress, and yes, this isn't going to make her feel any better, but I can tell, like, somebody, like somebody who knows, like, I know her well, I know that she absolutely needs to hear this. And, I'll sit with her and hold her hand, and we can talk about things and hopefully make her feel better, but she absolutely needs to know. But on a whole, it usually tends to weigh the opposite way, where it's like, well, she's just wondering and we can distract her. Or she just, like is missing him right now. We can talk about, like good times and help with that. But always look for the reason. And even if you're seeing a behavior, I hate to use the term behavior, but if you're seeing something that, like they're unhappy about something, look to see, like, is there a cause for this? Does this always happen at 4 o'clock? Maybe, like just kind of investigating, like, are they hungry? Is it hot? Are the clothes uncomfortable? Like what could possibly be going on that they can't express, that we can change and do something in the environment to make them feel better. So just being an investigator and looking for the reason why they're either asking for something or upset about something, and that can be helpful. All right, I've talked way too much about all that. Okay, so the moderate stage is the longest stage. Alzheimer's usually, we don't do a real good job of recognizing that's happening early. So like this, this stage is definitely where things start to click more with those of us who are like, oh, wait a second, this isn't just, random forgetting something, or there's more to it than that. So this is the time when a lot of people get diagnosed, and not necessarily just because it's not like we don't recognize it. You can definitely recognize it earlier than this. I don't mean that. It's not like an illness you want to go get diagnosed. Not that there really is one, but at least with others, there are treatment options and opportunities to get to work to make it better. And this one is oftentimes wrought with stigma and just refusing to want to accept that there might be something wrong. And so, and there isn't that like, well, I'm not going to leave the doctor's office with like a treatment plan of how I can attack this. So, it can be difficult for people to go. And also individuals with Alzheimer's often don't recognize that there are problems. And so that's just kind of a symptom of Alzheimer's. So there can be a lot of refusal it's on their end, because they don't see any, they truly don't see anything wrong. It's not that they're trying to like get out of like, oh, I just don't want to do this. It's like they just don't see that there's something happening. But what you might find in this stage really, it's a longer stage, but you will see these kind of like escalate and get more and more difficult. But seeing that more emotional, getting more emotional, having more trouble with language, more forgetful. You might see some this moodiness, withdrawal, like apathy, like I don't really want to go anywhere. I don't really want to do anything. And that could be because they are just like, it's just not interesting to me anymore. Or it could be that they're scared or overwhelmed when they do go out. And so it's much less anxiety provoking to just stay home and stay somewhere familiar. They may stop wanting to travel to different places that they don't know, may not want to spend as much time with other people. This is also a time where you'll see more changes in sleep patterns. And that is something that can be pretty extreme, like waking up at 2:30, getting a bowl of cereal ready to start the day. So it can be very off. And obviously when it starts off, then you're gonna like, it can be a bad cycle, because then you're awake at 2:30, you're gonna want to take a nap at 7 a.m., which is gonna throw you off for the rest of the day, etc. So those could be pretty significant changes or sleep pattern disturbances. And then the wandering too is something that not everyone has by a long shot, but this is kind of the stage where you'll see that. And people can be really, really good about like figuring out ways to sneak out. And so that can be a big trigger for safety issues, for making sure, well, it can be a big trigger for safety issues. And you might want, at this point, some people think about long-term care, just as a matter of not getting any sleep, have to be watchful and observant 24/7, worrying that something's going to happen. I definitely have had families where this was kind of like an impetus where, a wife was walking in short sleeves in our 20 below weather, and just, the husband tried all sorts of things, including putting an alarm on the front door. And then she would just time it so that she would leave when he was in the bathroom and like couldn't get out right away. So it became very, very difficult. And he was really worried for her safety. There are other families who a mom was walking, eating poisonous flowers off the side of the road, kind of a thing. And that was like, she was living alone and they just couldn't, it was too scary. She also had a bowl of her medication like as a candy bowl, like it was just all like, and so that was kind of like, the safety issues here are just overwhelming, and we need help. I will say I probably have a slide on this too, but it's just an interesting little piece about wandering. People usually turn the direction of their dominant hand. So if that happens, look to where, if they're right-handed, look right, because that might be where they are. And going back to familiar places is another thing that people often do. In the late stage, the severe stage, that's when you see more physical changes, difficulty with swallowing and walking and sitting. That's when they can become very vulnerable to infections. A lot of times with Alzheimer's, people don't necessarily die of Alzheimer's, but more of some kind of opportunistic infection like a pneumonia. But they're, just more cognitively, there's issues with communication and being able to talk, you may find that there's not that communication. Staying awake is difficult. Just needing more help with all their daily activities, toileting, etc., eating. Yeah. Let's check. Maybe let me stop again before we get into the risk factors and see if there's any questions about kind of the behavioral cognitive aspect of Alzheimer's before we get into this next section. And again, if you do have questions, feel free to email me too. All right, so risk factors. Age is the biggest. And so that's like, I think, a really important piece because people often ask about genetics, risk factors for Alzheimer's, and there, as you could see from the screen there, if you have a parent or a sibling or a child with Alzheimer's, you're more likely to get Alzheimer's, but it's not like for sure. It's not like this 1-to-1. It's much less than that. The biggest risk factor is age, and really with genetics, it's a really small. There's not that many genes per se that they've found that cause the disease. If early onset or young onset Alzheimer's has a much higher genetic component. So if your parent had early onset Alzheimer's, which is different from regular Alzheimer's, then you are more likely to get it because it's more genetic. But regular Alzheimer's, that's not the case. But if you look at age, in general, most people who develop Alzheimer's are going to be 65 or older. But if you look at the next two bullet points, I think it's pretty shocking. It's like after 65, the risk of Alzheimer's doubles every 5 years. And then at 85, the risk is almost one out of 3. So, excuse me. So it's really, age is like a huge risk factor. And that's something that, we really can't escape. In fact, across the world, the rates for Alzheimer's are actually going down. But because our population is aging so much across the world, we actually have more people are going to be developing Alzheimer's, even though the rates itself are going down. And the theory on why the rates are going down is because of that heart health message that we have, we've kind of been told about for years and years now about the whole thing, eating well and sleeping well and making sure you exercise, and just like those basic, don't smoke, those things, basic health issues or talking points are what they feel has also helped impact the rate for Alzheimer's, because we've done such a good job at that people are following that, and that's helped with Alzheimer's. But unfortunately, it's just that, there's just so many of us getting into those older age brackets that it will have more people with Alzheimer's, even though the rates are going down. There are a few others. Women are more likely than men to develop Alzheimer's. Latino or African American descent, more likely. Mild cognitive impairment, which we talked about. Head injuries, especially multiple head injuries. And then poor health, which we've talked about as well. And lower education, which we talked about too. These are, okay, so I've talked about that last bullet point, but these are just some pieces just to kind of let you know kind of where Alzheimer's disease stands. It's the 6th leading cause of death in the United States. And it's just going up. So like every 66 seconds now, someone develops Alzheimer's, but we're looking at every 33 seconds by 2050. So it's just the rates are getting higher and higher. Or not the rates, the numbers are getting higher and higher, but not the rates. And these are just some more numbers. 6.2 million Americans in 2021 have Alzheimer's. And so that's, a sizable portion. And that is not right. I think that I'm looking at our thing, it's like estimated 2.7. That is not right, because it's not going to go down. So don't pay attention to that. Nearly worldwide, that we have 55 million. So it's a huge worldwide issue. But I do want to take a second to talk about that younger onset, which, as you can see, is a much smaller proportion, 200 to 400,000, 100,000. But let's pop this up here. It is a significant, it's a significant diagnosis for many reasons, but it's significant for how it impacts family and caregivers, because it is something that happens early on. We're talking 40s and 50s where people aren't expecting it. The impact that can have on a family is just huge. I mean, I think on some level we all think of Alzheimer's, it's an older person disease. So when it happens earlier, people just aren't expecting it, and we don't have the same supports. Like, there's a lot of great support groups for Alzheimer's, but the early onset, it's because it's so much more rare, it's hard to get a support group going for it, or to find that, like other people who are going through the same experience and have that. It can be really difficult, for someone in their 40s or 50s to talk to somebody else, like to find somebody else who's going through a similar situation at the same age. So that can be very difficult. Even just like the way our medical and kind of like insurance systems are set up, it can be a lot more difficult. Like you can get Medicare, and you can get on different programs for older adults, but like somebody who's developing this, who has early onset in their 40s and 50s, they don't have access to those same programs. So it's definitely a very difficult disease. And it is, as I said, it has more of a familial, where like you're going to find that the genetics play a bigger role in developing early onset than in regular. All right. I just completely copied these from the Alzheimer's Association. So you definitely check out their websites because they have excellent information. But this is kind of like their warning signs for Alzheimer's. And I think before I go through each of these individually, just want to say, like, overview, the take-home message is that if something happens occasionally, and then you kind of like figure it out, it's not like, that's normal. We all have those. It's a problem if it's something that happens often, or if it's something that's happening with things that you shouldn't, like familiar things, then it's an issue. So first one, memory loss that disrupts daily life. So forgetting recently learned information. And that's something that is gonna, like, it's not just like a one-time thing. Oh, I forgot her name, or I forgot where I wrote that down, or something like that. That's normal. Occasionally normal. Going into a room and saying, what was I here for? Normal. Going into a room looking for something and then just sitting down and watching TV and not thinking about what that was, and that happening often, that's where you start to think, well, maybe that's something. Second one, challenges in planning or solving problems. So this is almost the exact example of someone that I talked to, but like trouble following a familiar recipe. It's like, mom never had trouble making this, and now like she doesn't remember it. She needs the recipe. She doesn't remember where the recipe is. She forgot to put in the eggs. That, like where you're seeing more of that, occasionally forgetting something, not to be worried. The next couple, difficulty completing familiar tasks, confusion with time and place. These, again, both of these are kind of falling under the umbrella of like something that's familiar is going wrong. So like, it's a sign of something that might be happening if you're not able to drive to the grocery store like you used to be, or you're not remembering the rules of something that you normally are able to do. if you occasionally need help with like the microwave, that's not an issue. If you're confusing dates and times, and I don't know how I got to the grocery store, I don't remember what I needed here, that's more of a problem. If you writing, oh, what is today? Oh yeah, it's Wednesday. That's not a problem. I think the piece, about remembering it later is important to kind of highlight, because it's like, what was that guy's name? And you might like, it'll bother you. What was that guy's name? And then you forget about it for a little bit. And then you come back to me like, oh, I remember what I was thinking. It was that guy, Henry. Like that is normal. I mean, it's not fun, but we all do it every so often. But like, this is just more like, it just skips out on you entirely. And you don't come back to it, and it doesn't, like take up a lot of your mind space trying to remember it. All right. Next two, difficulty with vision or spatial relationships. So that's like, with vision, it's even more about just like misrepresenting what's there. So like difficulty reading is one of the things here, but I find that is often something that is not impacted till much later. So a warning, like I think that would be a later warning sign. But even like there's different kind of visual things that happen with Alzheimer's, like seeing a pattern in the carpet might seem like it's holes in the ground, and you don't want to walk over it. Trying to spatially navigate how to walk up a stair or step off of a curb, like that kind of visual, like in spatial, like how far do I put my foot out, how like, and I've seen, I saw my grandfather trying to navigate how to take a step up into the house and not be able to do, like just be paralyzed almost with like trying to figure it out. And so, it's like, it's things like that, which are more visual, spatial, but not so much like clarity of vision. It's not so much like I'm having trouble, I need glasses. It's more of like what I'm seeing is not what is actually there. Like a hallucination, which is pretty common. We talked about it with Lewy body dementia, because it is very, very, very common with that. But even with Alzheimer's, it is common to have those hallucinations where you're seeing something that's not there. And it's often something that's more emotional. So it might be like a child who needs your help, you can't help them, or there's somebody outside that's looking in your window. And, so it's not necessarily just, like hallucinating that there is, something wonderful happening. So there's that. Number 6, new problems with words when speaking or writing. So new problems being that this isn't these are problems that are new. Like you haven't had issues speaking. If you've had issues speaking before, then this is all kind of new stuff. Like trouble joining in on conversations, trouble following conversations. You probably have seen that, where it's just, you can tell that they're not, it doesn't seem like they're paying attention. And people with Alzheimer's are good at having like a pat answer to things. You might have noticed this in your experience too, or they just know what to say, like, oh, I don't know. Oh, I think so. Just whatever it is. It might not answer the question, but it just has the right tone and lilt to it. And it's just like their standard thing to say, that it feels right. But it's not necessarily. I'm sure you've seen that. But having trouble finding the right word is normal. It's something that I struggle with daily. But it's definitely, like, I know a lot of people are like, oh, I can't remember what that was. I think I might be developing Alzheimer's. It's not something as simple as just not remembering a word. It's much more involved. Misplacing things and losing the ability to retrace steps. We talked a little bit about, like, if somebody puts a phone in a shoe, that's like one of those things. It's like a shoe in an oven to warm it up, or like it can lead to unsafe things. But there's definitely like the placing of things in places where it makes no sense that they would be. Also like an inability to kind of like, okay, well, where did you see it last? Like, I don't know which room I was just in to do that, to like go through that process of, okay, I first was in the laundry room and then I went to the kitchen and now I'm here. So, and it has that bullet point too about accusing others of stealing, again, because if you put it where you put it and it's not there, somebody else must have moved it. But misplacing things from time to time, not a problem. Judgment, issues with money, that's a huge one. Poor grooming, that again kind of falls under that visual thing of not being able to see stains on shirts. It falls under memory of not being able to remember the last time you showered. It falls under all your dirty clothes, or you just put your clothes right, like I put it on my chair, I put on my pajamas, I go to bed, I wake up, oh, look, clothes are on the chair, I'll wear that. And so it's not necessarily like you're intentionally doing poor hygiene. It's just that, well, there's my stuff. So if that's an issue and you're living with that person, making sure that those dirty clothes go into the laundry or laundry room and out of sight, out of mind is a good trick. I know that there are people who are very, very attached to some articles of clothing. And so, in that case, it's going to be a lot harder. You might need to get multiples of certain things so that they can wear their comfort uniform without, and you can wash one while they're in theirs. And the last couple, that withdrawal that we talked about, being more apathetic, not wanting to join in as much because it can be overwhelming. That's different than just having a tired day. Changes in mood or personality. Again, we've talked about the paranoia and suspicion. Being more anxious, obviously, when things, remember things and things are disorienting, it's easy to be confused. It makes sense that you'd be anxious. So, and what's normal is doing very specific things, is having very specific ways of doing things and being irritable when they're disrupted, which if anyone has I need the dishwasher done packed a certain way, things need to be in there. That if you have a tendency like that and somebody changes things around, that feeling. Anyways, so this next section is on diagnosis. So following the risk factors and warning signs, are there any questions before we jump into diagnosis? Okay, I will continue on then. So as I noted before, most people don't get diagnosed until they're in the moderate stage. We really recommend excuse me, early diagnosis if it's at all possible, for many reasons, not the least of which being that many of the drugs we have for treatment, again, not a cure, but for treatment, are work better in the milder stage than the moderate stage. So I will talk about medication, but just because it flows with this. Most of the medications, there aren't many, but the research, and I'm not talking about the new Aduhelm, I will talk about that separately, but the others that are out there, I talk like Aricept and those. The research on them is pretty weak. It shows that you're going to get, ideally, in ideal circumstances, 6 months of not having any more symptoms, and then progression will resume as it would. And 6 months is great. I mean, honestly, the 6 months is great, but it's, we definitely want to do better than that. There are some pretty significant side effects as far as quality of life, like nausea, needing to go to the bathroom a lot of people aren't able to stay on it just because the side effects are so, they just deteriorate quality of life. So anyways, not that say, so that grain of salt with that, but early diagnosis, you could get onto treatment that might be more beneficial early on. And that would be the case with a new medication that I'll talk about as well. But also just practically, it gives you a chance to plan because you now have a diagnosis, what the trajectory is, what your future years will look like, and you can have a say. You would be able to have the conversation and to voice your opinion and say, hey, this is what I want. When I get to this point, I want 24/7 nursing in the home. I don't want to go to long-term care. I want to move now to senior living at a place that also has assisted living and memory care down the road. That way I can just move from there. Like just kind of making those plans and being able to participate in that is huge. By the time, you're moderate, you have less ability to be able to have those conversations and to really actively participate in like how, your advanced care planning and all the rest. An early diagnosis gives you time to really kind of set up a good relationship with your healthcare providers, with your with your care partners. It really helps with that. There are a lot of, Minnesota is fantastic for having support services and different kind of organizational help and community help that you can take advantage of. There's opportunities to participate in clinical drug trials and other kinds of research if you, if you're able to get that early diagnosis, that what you are eligible for. But it really, it's just, I'm not gonna say it's peace of mind because it's not like you're getting, this great news. Oh, it's not a relief, but at least okay, this is what's happening. This is what we need to think about. And you can make those steps to plan and prepare for the future. And, most decisions made under duress are, not only just stressful on their own, but they're not necessarily the best made decisions. I don't know the percentage, but it's pretty high, maybe like 60 to 80% of long-term care moves are because of a crisis, whether that be the person with memory loss is experiencing some crises that they need to go into long-term care, or if it's the care partner who broke a hip and isn't able to be at home to provide that 24/7 care. So, the option is that they have the person with memory loss has to go into long-term care to get that supervision while we, and in some cases it may be like, well, now this has to be your, like where you're at. You can't just go back home because she's not going to be able to take care of you even after that hip heals. And so those are, like situations where it's very stressful. You have the hospital once, you need to get discharged, you can't be home. Okay, well, I have a few days to be able to figure out where someone's going to go to live. And I want it to be at a great place. And there's all these things that go into like making that decision about where's the best place for someone as far as residential care. So you don't get the opportunity to do any of that planning if you kind of wait too long. So for diagnoses, it's not great because we don't have a specific test. We don't have like, if this panel comes back this way and the lab results look like this, then you definitely have Alzheimer's. Basically, it's a diagnosis of history and behavior, and it's a diagnosis of let's rule out everything else. So that's essentially what people do. you can go to a neurologist or a psychiatrist or a neuropsychologist or a geriatrician, or, like there's family practitioners can do, I mean, it depends. Some family practitioners are better trained or, more comfortable than others, but, like in general, you're probably going to go to a neurologist or a geriatrician. And they'll start by ruling out other things that could be going on that could be leading to memory issues. Like, are there medications that you are taking that could be, combined and having this effect that's causing these memory issues? Could it be a vitamin deficiency? Could it be this? Could it be that? And so they rule all those out. They also are talking to you, the person with memory loss, are talking to family to get a history of, like, when did you first notice these symptoms? What kind of symptoms are you seeing? How often do they happen? Have they stayed the same? Are they getting worse? Kind of just to get a really good history of what's going on, because that'll help distinguish, like Alzheimer's kind of has this like kind of slow step progression where maybe a vascular dementia might happen a lot quicker because like there's a stroke and then this happened. Like we started to notice right away that things were different. Where Alzheimer's is more like, well, now that I think back, she started just not remembering to do things, 10 years ago or 5 years ago or whatever. Anyways, that's part of the process of trying to figure out what dementia it is. There are some screening tests that they use. I have them listed there by their initials, which isn't very helpful, but the mini mental status exam, it's kind of used. The mini cog is more used. The MOCA is probably the most used of those screeners. It kind of gives an idea of what's happening at that point in time. The CPT, it's a performance test, which is, it's really interesting. A lot of times like occupational therapists give it. And it really kind of looks at practical things like if I was to give this tray of vitamin, or a vitamin tray, could you put in the vitamins for the week? And it kind of like steps down, like, okay, if the person can't do that, can they do it for 2 days? Can they do it so it's really practical. I'm not explaining it well at all, but it's really these practical tasks. And they try to see where, how well you can do on those and where you're at. And then you get this result like, okay, well, they're at this point, and that helps because it gives you practical information about what someone is capable of doing. It also impacts safety. Are they okay to live alone? Do they need help? Do they need somebody in their house a few hours a week or all day, every day? What are they capable of doing? So that's good. Internet home screening tests aren't the greatest, and I wouldn't recommend that as a way of diagnosis because there's just so much more that needs to be done. Depending on where you go, because every memory clinic does things differently. But, you may have a long, a 3-hour appointment for assessments and diagnosis. You may have a 2-day where you go in for an hour here and an hour and a half there. It may just be an hour. It really depends on who makes up the team and what services and assessments they can provide. But it's not as simple as just doing a little screening online because there's so much more to it. I've talked about the lab tests they do and the testing types. Most of the time, some of the brain scans they're very expensive, and they're not necessarily going to be part of your assessment. Sometimes if they suspect something or if it's a very tricky dementia to diagnose, they might do it. Some places just do it, but it's definitely not a standard part of an assessment. But they can help like you see, they can, you can look and say, oh yeah, I see the evidence of plaques and tangles here, or I see evidence of this or that. But they're, you know, $5,000-$10,000. So it's not like it's a standard. But I think Mayo, I know the University of Minnesota has a scan machine. That's it's not really the technical term for it, but they have clinical trials that they're doing that they have participants. If they're in that clinical trial, they have access to those machines for free, and so they can do those scans that way. But they do have the capability. A lot of places don't have that capability at all, regardless if they're running clinical trials or if you pay out of pocket, which some people will definitely do to get the diagnosis. And some insurance will cover some, but it's real, it's spotty. Before I jump to this, what I will say though is what people are working on in the research world is to get these biomarkers and to get biomarkers where you can look at whether it be blood or a certain level of something, to be able to figure out, okay, is this person have Alzheimer's? They're able to do it to a degree, but it's really expensive right now. So they're trying to figure out better ways because there's no way insurance would pay for it. It's way too expensive. So they're working on that, but the biomarkers is really like this new wave of research that has really taken hold, because not only would it give you more of a diagnosis, like you would, instead of like it being, well, you know, it looks like it's not this and it's not that, and from what they're saying it's this, you know, like instead of that kind of a diagnosis, or these scans that are costing not hundreds of thousands but tens of thousands, to just do a simple, and you have to go in and get the scan, which is a lot, you know, that's a lot to, you know, have to do versus a blood draw. So they're really trying to get it to something like that. But if they've found out, and this is like pretty new information, and people are really excited about this finding, is that we can see changes in the brain 20 years before we see symptoms of Alzheimer's. So things are happening 20 years before. So that, you know, if we can figure that out without, like, you know, looking in the brain, if we can get that information from a blood test, from a simple biomarker, and know, okay, we have 20 years before we might start seeing some signs of Alzheimer's. That's like 20 years of opportunity to prevent that from happening, to treat whatever's going on, to fix things. So it's huge. And so the biomarkers would be a huge part of that, because they would let us know simply and easily. I mean, can you imagine? You just go to your regular doctor's appointment, get a blood draw. Okay, we see something here. Let's start this. And you have this medication or this, you know, treatment program that it's going to impact, and you will never see the Alzheimer's progress because you've been able to use that time to stop it. So that is really exciting stuff. This prevention, we've talked about this, just about prevention and how, you know, like, again, heart health, sleep well, eat well, exercise, take care of, you know, manage diabetes, obesity, don't smoke. That can all really help. And then the other piece that I haven't been talking about as much is to be active, both cognitively, like read, do crossword puzzles, learn, take classes, just, you know, keep your mind busy, and being socially active, because that is a piece that I have neglected to talk about or emphasize as much. But not being active socially can really impact not only quality of life and possibly lead to depression, but it also can impact your chances of getting of developing dementia. So, you know, as people get older, they often, you know, don't have those kind of same social opportunities or they don't take advantage of because there are a lot of social opportunities out there. But we just really need to make sure, especially in the time of COVID, that we're keeping everyone engaged, because the more engaged you are both cognitively and socially, the better it is for reducing your chances of developing dementia, and for just being overall, improving quality of life. So that's a big piece. And, one more thing, just especially, if you're thinking of like spouses whose the other spouse has passed, or someone who has retired, and so they've stepped away from their work environment, which has been both socially engaging and cognitively engaging. So there are some changes that happen with growing older that can affect that. If you have some physical issues that require you to stop driving, then you're more likely to be less socially active as well. And so just trying to keep people busy and active, it's an important piece of being a good community to our older adults. These are just some ideas which I basically have covered about how to stay cognitively active and socially active. Other ideas we've talked about. I guess I haven't said volunteering is great. It's not only great for your social life, but it's good for your soul. So it definitely helps people's emotional health and well-being. So a plug for volunteering. Doing other kinds of clubs and traveling is good. And we've talked about physical activity and eating well. And so eating well, kind of steering clear of more fatty foods. And when I say steering clear, I don't mean like just swearing it off completely, because everything in moderation. But like trying to make good choices about how much to have and when, and then just the general fruits and vegetables. And there's definitely diets out there that are very are marketed as dementia prevention, and they can, that kind of sounds like I'm judging it, and I'm not. They're just, some of them are very, very difficult to follow. So more power to you if you can do it, but some of them are very specific, like only blueberries, no other kind of berries, and only this kind of fish, and it can be difficult. Fruits, vegetables, fish, good. Body weight, vitamins. Some people have found that vitamin E, or E and C together, B12 and folate are helpful. We talked a little bit about these medications. These were the ones I was talking about, like Aricept and Nimdia. But I really want to talk more about this new one. And I have put this up here so I remember how to pronounce this big word, but I think it's good for everyone. Aducanumab. So it is, luckily, in its medication form, pronounces Aduhelm, which I can do. I can do that very easily. So it's the new drug, and I'm sure you've all heard of it because there is a lot of news and press on it. I don't want to get too into the controversy of it, but it definitely is viewed in the community, in the Alzheimer's disease research / academic community, with a very wary eye. The way it was approved is very different than other drugs, and there are a lot of raised eyebrows about it. But even aside from just like that approval process, the research that they've done on the drug is it doesn't show that it should have been approved, basically. So I'm just going to go through these bullet points. again, as with any drug for Alzheimer's disease, this isn't a cure. It's a treatment that may slow the progression. These other drugs, I've said the side effects can be pretty bad, but those side effects are more like uncomfortable quality of life issues. The side effects for this drug can be more impactful, like swelling of the brain or small brain bleeds. Now, not necessarily, and that's in 40%. So that's like a huge number. And 40% of people who took this drug in the trials, there was some of these side effects. And swelling the brain sounds horrible. And maybe it sounds worse than what the actual impact was on the people who had it, but it's still bad. Like, still not a great thing to have. So there's that is one of the reasons why people are very hesitant about, because the side effects are so strong. Another piece is that instead of it being a pill or a patch, it's an IV infusion where someone has to go in once a month for 1 to 2 hours and have this IV infusion. And so something to consider with that is just, how will your person with memory loss, how will that go for them? Well, is that something that you think they'd be willing to do? Is that something that's going to scare them and make them very anxious and uncomfortable? Is that something that it's going to be really difficult for you to take them to, because it's hard to get out of the house and get there? Like, what is that going to do for quality of life? So that's a piece of it. There are a lot of scans that you will need to get. None of this at this point is, like, the payment for it hasn't really been decided. It would cost $56,000 a year, and that's without the scans. And so trying to figure out, like, is Medicare going to pay for that? And if they do pay for that, there's a lot of questions about, will that just blow up the program because it's going to cost so much that the program doesn't have the funds to cover that, and everyone's premiums are going to go way up, and there's all the, there's a million different thoughts and theories on that, and who knows? We'll figure it out in time. But a lot of bigger clinics and bigger clinics aren't going, like the Cleveland Clinic, and I might have some on the other page, but there's some clinics that aren't going to give this as a treatment option even. The other piece of it that I think is important too is that and with the scans, and you got to think too, is my person going to want to go and get all these scans? Like, how's that going to work? So there's that. But this was only tested on early stage Alzheimer's patients. So, like, we have a lot, and no persons of color. So it's really, like, they're not the most robust findings, and done on a wide range of patients in various stages of Alzheimer's, which is what it should be. But, there's still some question as to whether are doctors going to prescribe this to someone who's in moderate or later stage Alzheimer's. I don't know if they will or not, but it was only tested on early stage. And even as that is, the results weren't clear as whether it was helpful or clinically helpful. Like maybe a point was higher, but does that actually translate into real world? Did it help someone? Were they any different? Oh, yeah. Okay. So this is a link to this really good symposium that I definitely recommend if you have a chance to watch that, because it's fantastic. And then just a few more things that the VA is not putting in their formulary. Mount Sinai, Cleveland Clinic aren't going to use that either. There's a former senior medical director for Biogen that spoke out against it. And that was a person that worked on the clinical trials. There's 2 House committees, US House committees, reviewing the process, like, how did this get approved? So there's a bunch of controversy with it. We'll see how it all washes out, but I just figured it is important to let you know the background of what it, what's happening with it, and yeah. So I think it is now 8, so I will probably need to sing, but just real quickly, there are some non-pharmacological interventions like changing things in the environment. Music therapy is fantastic. Art therapy is fantastic. Reminiscence, talking about old memories in specific ways. It's fantastic. Exercise has been great. There are definitely interventions that can be done that are helpful as well as these medical treatments. There. We have, oh, let me put up my, these are all the ones that I have, all the slides that I have. Here, this one up. My email number. Email is probably the better way because I'm not in the office. But if you have any questions, feel free to email or call. And if there's any that anyone wants to bring up right now, I can take those too.
I just want to reiterate too what you had mentioned at the beginning, Robyn, that I will be putting the PowerPoint presentation out on our website along with the recorded version of this, and also the list of the other resources that you had supplied prior to your presentation. So all of those will all be out at the library website in the next couple of days. So if people want to go back and look at, some of the other slides that you didn't go over, and if you did, if there was any, other particular one that you wanted to quick hit on before we closed up, we could do that too. I suppose it's kind of hard to know which ones people might need the information on, but if they can contact you directly as well, I guess that helps. So, but yes, all of this information will be out there. So any questions from those here? Okay.
All right.
I guess that wraps it up. Thank you so much for all the
you're welcome.
information. Thanks for taking the time tonight. We really appreciate it.
Thank you.
You're welcome. Thank you.
And thanks. I'll be in touch with you too. So thanks.
Okay, sounds good. Thank you.